Hi, everyone. Welcome to OR Today webinars. We have a great presentation for you today by Linda Homan. Linda will provide examples of hospitals that set a goal to significantly increase cleaning efficacy, achieve faster OR turnover, and identify cost savings. She'll review clinically proven environmental hygiene tips for just how they did that. OR Today would like to thank our sponsor, Ecolab. Ecolab's healthcare business offers a comprehensive array of infection prevention solutions targeted for healthcare facilities, with the goal of creating cleaner, safer, and healthier environments for patients and healthcare providers. They focus on broad-based infection prevention programs and solutions to address critical sanitation and contamination control in the hospital environments through digital analytics, advanced chemistry, and on-site service and professional training and process support. Please visit ecolab.com/healthcare for more information. For nearly 20 years, OR Today has provided perioperative and SPD professionals with up-to-date news and information about their profession, including new guidelines, techniques, and equipment, as well as practical information for career building, problem solving, and overall well-being. Please visit ortoday.com to sign up for your free subscription. Today's webinar is eligible for continuing education credit by the State of California Board of Registered Nursing. You can obtain your CE certificate by completing today's post-webinar survey. More details on this at the end of today's webinar. We'll wrap up today's presentation with a live Q&A. You can submit your questions at any time during the webinar by using the questions feature on the GoToWebinar dashboard. We'll get through as many questions as time allows. As I mentioned earlier, our speaker today is Linda Homan. Linda, you may begin whenever you are ready.
Great, thank you very much. And thanks to everyone who is taking the time to join us today and talk about this topic. And hopefully you will learn some really good things during this time. And with that, I'll get started. So first of all, a little bit about the objectives of what we're going to cover today. I want to talk about some guidance and best practices for how to balance safety with faster room turnover times. So specifically, this talk is about operating room turnover and the work that happens in between wheels out of one patient and wheels in for the next patient. And so we'll be spending some time talking about how to optimize that room turnover. And within that, even more specifically, how to optimize the cleaning part of that so that you have time for the other important patient safety things that have to happen outside of cleaning. And so as part of that, we're going to describe how to clean better with fewer staff. And we're going to talk about ways to improve the cleaning of critical high-touch objects. We'll talk about ways to enhance staff training opportunities and also some ways to improve efficiency and save time during that room cleaning turnover process. But first, just a little background, and I feel like I'm preaching to the choir a little bit here because you're all living this every day. But COVID and other emerging pathogens are just continuously creating challenges for healthcare. And especially related to COVID, hospitals' revenue is showing challenges. Elective surgeries are being postponed due to COVID, and specifically now again because of Delta variant. And then in addition to that, COVID is just recently, some studies have come out that have shown that COVID is also having an impact on other healthcare-associated infections in the hospital, in part because the patients with COVID are more susceptible to those healthcare-associated infections, and also in part because of staffing shortages and staff burnout and just being plain busy and sometimes taking their eye off the ball when it comes to some of those fundamental infection prevention practices that have to happen. And so that makes patients in general more susceptible to healthcare associated infections. And COVID is, of course, top of mind for everyone right now, but there are also other organisms that we have to be concerned about. And the other one that's listed in the news lately is Candida auris. And this is an emerging fungal superbug that has become a growing threat in the United States, and in fact is in 18 states in North America right now, most prominently in Florida, New York, Illinois, California, and New Jersey. But in 18 states altogether, we are starting to see increases in transmission of this Candida auris fungal infection that is resistant to treatment with antibiotics. And the way that that ties into the conversation today is that Candida auris can actually live for up to a month on environmental surfaces if not removed by disinfectants. And not all standard disinfectants are effective against Candida auris. And so we're going to have to be thinking about how we're going to manage that as we start dealing it within our hospitals and your communities. And so all of this to say, you're facing a lot of challenges, and a lot of these challenges can go back to environmental hygiene and that fundamental activity of preventing the transmission of infections. And it creates a very important balancing act. As we hope that COVID will wane eventually, surgical volumes will increase, but we'll still be challenged by staff shortages, by staff burnout, and potentially supply shortages. And that's going to make that delicate balance of optimizing efficiency, patient safety, and staff safety really critical and really challenging to do. And so specifically, how are we going to optimize all of those three aspects during surgical room turnover? So I want to just ground everybody a little bit on what this room turnover process is. It's a very fast dance that has to happen when a patient is wheeled out and before the next patient comes in for the next surgery. And on the left, you can see a little clipboard that shows all the steps in the room turnover process. The patient is wheeled out, and then they bag trash and linen, they remove the soiled instruments. The anesthesia team has to turn over their equipment and clean it and put new tubing and things in place. Everything that was touched or used during the surgery has to be wiped down. You have to swap out mobile medical equipment because different equipment might be used in different procedures. You have to make up the OR table. And all of that's done before you can open for the next case. Then you open instruments, you count and prep and get ready, make sure you're set up for the next case. The anesthesiologist makes sure they have their medication set up for the next case. The patient gets interviewed by the RN, and then the patient is wheeled in. And all of that, because we're trying to be cognizant of time, really is accomplished within 30 to 55 minutes. Of course, it can take longer or shorter depending on the type of procedure that's done. An eye procedure takes much less time to set up for than a large orthopedic or cardiovascular procedure, for instance. But there is always, as you know, a specified time that you're shooting for in room turnover because you want to have efficiency. And I've heard some studies who refer to this room turnover process as lag time. And I really sort of take exception to that because it makes it sound like it's wasted time, when in fact, when you look at what's happening during this room turnover process on the clipboard there, it's all very important steps that have to take place to optimize patient safety and staff safety. And then I'll just point out that the cleaning and disinfection steps in this room turnover process, the ones that are listed in blue on the checklist, normally take 10 to 29 minutes according to surveys that have been done across the industry. And so you can see that that leaves a little bit, a lot less time left for some of those other very important things that have to happen: opening instruments, counting and prepping, making sure your medications are managed. And so if there's a way that you can optimize that room cleaning time so you have more time for things that are very patient-centric and patient safety focused, it would be a big advantage because it can really assure that you're ready and set up to go for the next case. And so that's what we'll spend some time talking about today. So why do we worry about environmental hygiene in the OR? I think people probably already know the main reason, but surgical site infections are the driving force behind the importance of environmental hygiene in the operating room. Surgical site infections are the most common, one of the most common and costly healthcare associated infections. And studies have shown that the average cost of one surgical site infection is $34,000. And of course, we all know that there are also reimbursement penalties for certain surgical site infections, such as hysterectomies and colon surgeries. And then also, just from a PR perspective, HAI information is all publicly reported. And so you want to make sure that you can minimize that impact on your hospital's reputation by having high rates of surgical site infections reported. And there are a lot of factors that impact the risk of surgical site infection. And we won't go into all of those other risk factors, but environmental hygiene is definitely one of the well-recognized risk factors for surgical site infection. And so that's why we care about environmental hygiene in the operating room. And behind all of that, it's because of the chain of infection. So there's just a really continuous transmission of pathogens between patients, healthcare workers, and surfaces. And our goal in everything we do in the hospital, and especially in the operating room, where asepsis is so important, is to break that chain of transmission between patients, surfaces, and hands. And there are really only so many ways you can do that. You can do that with patient antisepsis, patient skin antisepsis, which is a whole different talk about how to ensure that the patients decolonize prior to surgery and their skin is as clean as possible. You can do that with hand hygiene, and examples of that in the operating room are obviously scrubbing in and sterile gloves and sterile gowns. And then you can do that with surfaces. So ensuring that your surfaces are as clean and free of bioburden as possible. And all three of those things have to take place in order to break that chain of infection. And just to illustrate the role of the environment and the way that it interacts with patients, I have a study as an example here. And so this was a really interesting study where they asked healthcare workers to do an abdominal examination on a patient with gloved hands, and then in a separate step, touch environmental surfaces with gloved hands. And what they found was that their hands were equally contaminated after contact with the environment as they were after touching skin. So if you focus on the darkest black bars on these graphs, you can see the overall outcome of those cultures. And then on the right side of the graph, you can see that not only were they just as likely to be contaminated, there really wasn't any significant difference in the amount of bacteria on healthcare workers' gloved hands after they touched the environment versus after touching skin. And so I think healthcare workers are all very good about doing hand hygiene after they touch a patient's skin, but maybe less likely to do that after touching the environment. And I think that this really illustrates that the environment does play a role. So again, hand hygiene can either, you can either combat this with hand hygiene or with environmental hygiene, or preferably with both, but they're very interrelated. And so this is a really hard nut to crack. I've talked about hand hygiene and environmental hygiene, and when we talk about compliance with these measures, these fundamental infection control measures in hospitals, this has been a tough nut to crack, how to ensure that people do this consistently and correctly. And I'll just say that change is very difficult. And as an example, when I was doing some research for another talk I was giving about the science behind compliance, I found that there are 83 different theories of behavior and behavior change that have been proposed. So obviously, no one has fully cracked the nut on how to change behavior. And as an example, if you think about the time and the money that is spent in this country on weight loss or smoking cessation or fitness, you know that it's really a hard thing to change behavior. And I do think, just as a caveat and as a little foreshadowing of what I'm going to talk about later, if you think about some of the most effective methods to change behavior related to weight loss or fitness, there are things like a Fitbit that give you constant feedback and monitor your activity, coach you and train you, and give you some feedback on your performance. Or if you think of weight loss, you can think of the weight loss programs like Weight Watchers, for instance, where people will weigh in, will get coaching, education on how to eat correctly, and get feedback on their performance by stepping on the scale once a week. These kinds of continuous coaching, training, monitoring, and feedback are some of the most effective ways to change behavior that we have today. And in healthcare, we spend a lot of time and money on continuous quality improvement programs for fundamental infection prevention measures like hand hygiene and environmental hygiene. And I'm going to be talking more about some of those ways that we can standardize that process and give people monitoring and feedback and coaching to continuously improve that process in healthcare and in the operating room. So we know that environmental hygiene is important. leading healthcare organizations like the Association for Healthcare Research and Quality, like the CDC, like the World Health Organization, all say that cleaning of hard surfaces in hospital rooms is critical for reducing healthcare associated infections. We all understand that, we all accept that. We also know that disinfectants work. Disinfectants are EPA registered by the Environmental Protection Agency, and that is to say that they have passed tests for efficacy and safety. So if you have an EPA registered disinfectant, you can have confidence that it's safe and effective. But there are failures that occur even so. And I just pulled some studies that showed, for using MRSA as an example, that failure to remove MRSA from environmental surface is most likely due to a process failure. Either failure to clean the surface at all, failure to apply the disinfectant for the right contact time, failure to apply it at the right concentration, or if people disinfect without cleaning first, because you always have to remove the organic soil before you can disinfect. And a good example that I have is during COVID, I go to the grocery store and they're very diligent about spraying down the checkout counter between every customer. But the truth is they spray the disinfectant on and they immediately wipe it off. And that really probably is not meeting the contact time. So they're going through the motions and they're using a disinfectant that's effective, but they're not necessarily following the process correctly. And they're wiping the disinfectant off right away, not giving it enough time to be effective. And so we know disinfectants work, and so yet we still have many patient care areas that are not well cleaned. And this is some studies that have been published that have shown that indeed we are not cleaning as well as we should be in healthcare. And the first one on the left was a sentinel study that was done in 2012 by the physician Dr. Carling, who was inventing a fluorescent marker system for objectively evaluating whether cleaning took place. And he went to multiple sites around the country and then different departments within those sites. So you can see that he went to 50 sites within the Iowa hospital system. He went to 16 operating rooms, 7 ICUs, 4 dialysis centers, 4 long-term care facilities. And in those facilities, he used the fluorescent marker, which has since been widely accepted and adapted as a really good objective method for evaluating cleaning. And he evaluated over 110,000 high-touch objects and found that only 32% of the critical surfaces were cleaned. And then if we took that a step further, as a subset of that same study, they looked specifically in the operating room, and they found that only 25% of high-touch objects in the operating room were adequately cleaned until they had implemented some kind of a training, feedback, and monitoring system in a standardized process. And so we know that even though environmental hygiene is important and disinfectants are effective, sometimes the process is what fails us. And so it's working on the process that matters. And the fundamental issue is really a lack of process control. And this study was done several years ago as well, and is a really nice, elegant study that shows that in this particular case, they evaluated how long it took environmental services staff to clean an area and what percentage of high-touch objects they cleaned in the time that they spent. And you can see, first of all, that it's a scatter plot. So there isn't any consistency in the amount of time or the number of high-touch objects that were cleaned. And some people cleaned 20% of high-touch objects and it took them over an hour, while other people cleaned 70% of high-touch objects in about 15 or 20 minutes. And obviously what you're looking for here, if you have a standardized process, is that everyone is cleaning everything quickly and well. And you have everyone on the upper left-hand corner, a quadrant of this graph, cleaning a high percentage of high-touch objects in a short period of time. And so we're going to talk a little bit more today about how to do that. And there are a lot of benefits that have been, since we've recognized that this is not a standardized process and that it needs improvement, there have been a lot of studies done to show the benefits of a standardized process. And I'm going to talk through a few of those. But this is a basic chain of arguments about how a standardized process can help. The first is, as I already said, that, or is that previously contaminated rooms increase transmission risk. So there are many studies that have been done that show that if the prior occupant in the room had C. difficile or some other pathogen of concern, if that room isn't cleaned well before the next patient is admitted, then that next patient is at higher risk of getting C. difficile. And then the next concept is the one we just talked about. There are studies that have shown that many patient care areas are not well cleaned. And then there are studies that show that if you use a programmatic approach, you can improve the cleaning of high-touch objects. And then the next concept is that if you clean those high-touch objects better, you decrease the bioburden on the surfaces in the room. And then most importantly, the last concept is that if you improve the cleaning of the surfaces, you decrease patients' acquisition of pathogens. And so I'm going to give you a couple of examples of studies that demonstrate that. So I showed you this graph on the left before. So this is showing that 32% of high-touch objects were cleaned. And if you look on the right, it shows that a standardized cleaning process can improve cleaning. So in this study, they did a follow-up where they went back and they did training, education, monitoring of how well people were cleaning, and feedback on how well they were cleaning. And they were able to show that they could improve the thoroughness of cleaning significantly after they implemented some monitoring and feedback. And so you can see here, specifically in the operating room where the red circle is, that they were able to see a 46% improvement in high-touch object cleaning after they educated people and gave them feedback and started monitoring how well they were cleaning. And so a standardized process can improve cleaning. And then if you improve cleaning, you can reduce environmental contamination. And this was a really good study that was done several years ago in a hospital in Florida where they were concerned about gram-negative bacilli possibly being a source of surgical site infections, a very serious outcome. So they were seeing an increase in surgical site infections, and they were suspicious that the environment might be contributing to those surgical site infections. And so they implemented a program where they educated people on how well to clean, and they monitored how well they were cleaning using a fluorescent marker. And they also took cultures of the surfaces in the operating room before and after this intervention. And you can see that before the intervention, over 10% of the surfaces in the operating room were contaminated with this gram-negative bacilli, which can cause surgical site infections. And then after they did the cleaning intervention and the education, their high-touch object cleaning improved from 47% to 82%. So a significant increase in the thoroughness of cleaning, and their gram-negative bacilli on the surfaces decreased to 2.3%. So a really good reduction. As cleaning improved, the environmental bacterial load decreased. I wish they had taken that study to the next logical step, which was to evaluate the effect of that on their surgical site infections, but they did not publish that data, so I can't say that. But we do have other studies that have shown that if you improve cleaning, you can decrease the acquisition of pathogens. And in this study, and this was in hospital inpatient unit, not specifically in the OR, but it was a large randomized trial across 11 hospitals where they implemented this process, standardized process of optimized product use, an optimized cleaning process, staff training, monitoring and feedback on how well cleaning was taking place, and then communication between departments. And what they found was that they were able to reduce Staph aureus bacteremias and VRE during this study. I'll note that they weren't able to decrease C. difficile, but I think that a limitation of this study is that they did not require the hospitals to use a sporicide for disinfection. And you obviously aren't going to be able to see an improvement in environmental hygiene or C. difficile if you haven't used a sporicide to clean environmental surfaces, because the environment plays a big role in the transmission of C. diff. And so that might have been a limitation. But they did see reductions in Staph aureus bacteremia and VRE. And so a very nice study that showed that if you improve this process, you can decrease healthcare associated infections. And then we've talked about the impact on patient outcomes, but what about the impact on efficiency? A standardized process can really improve efficiency. This is a study that we did internally that showed that if you optimize the number of people cleaning the room, you can actually optimize the amount of time it takes. And so this is an example of showing that if you have one person cleaning a room, it takes about 12.5 minutes. If you have 2 people cleaning a room, it's decreased to under 7 minutes. It stays about the same if you have 3 people cleaning a room, and it doesn't decrease much even if you have 4 people cleaning a room. And so a lot of times you see people, when you're turning over an operating room, you'll see a whole team of people come in, they'll all start cleaning, what happens really is that a lot of things get cleaned twice and some things don't get cleaned at all. And you really aren't saving a significant amount of time by having more people in there, but what you're doing is creating a little bit more confusion and it's harder to communicate what happens. And so there are ways that you can improve efficiency. If you have a standardized process, if people really understand what they're supposed to do and they always do it the same way, then you can optimize with potentially 2 or 3 people turning over a room. And because of all this evidence that's out there today, expectations are really changing. Healthcare industry is requiring evidence-based decision making, and I've just shown you some studies that show that there is evidence to support the importance of environmental hygiene in the operating room. And then AORN guidelines, the Association for Perioperative Registered Nurses, they have an entire chapter in their best practices on environmental hygiene, and specifically within that, stress the importance of doing some kind of objective monitoring of how well you're cleaning high-touch objects in the operating room. And then heightened awareness of the spread of viruses and bacteria in the past year has led to a new CDC surface disinfection guideline. And I'll show that to you a little bit later in the presentation. So next, I want to talk to you about some success stories. How have some hospitals solved this? How have some hospitals improved cleaning and reduced turnover time and standardized their process? So before I do that, I want to talk a little bit about what some of the common challenges are that hospitals see when they're trying to standardize this process. First of all and foremost, there is no standardized process for how process or products used for room turnover. So commonly we see that there are many different products being used. Maybe anesthesia uses a different product than the staff that's cleaning the room. Maybe the environmental services staff uses a different product than the clinical staff. Maybe you use a different product on the floor than you're using on the surfaces. And maybe you have to clean your monitors with a different product. And so all of these things create a little bit of confusion and a little bit of a challenge. And so one of the things that you want to do is try to standardize products as best you can and make sure that they're effective against the organisms of concern in your hospital. And then of course, standardize a process. The other challenge that we see a lot is that high touch objects aren't consistently cleaned. And I think I've talked about that enough already. It's pretty well established that cleaning isn't always as good as it could be. And part of the reason that it isn't as good as it could be is because there isn't any objective method being used to evaluate how well cleaning is being done and provide feedback to the staff on how well they're cleaning. And then from an efficiency standpoint, it could be that the turnover time is taking too long. A lot of hospitals have metrics for how long they want the room turnover to take. And a lot of times, if the turnovers are perceived to be too long, then the staff that's doing the cleaning are the ones who are asked to squeeze that time down and make time for room setup for opening up for the next case by the clinical staff. And so if you're going to squeeze the time, it's going to be very important that you have a really strong standardized process to make sure the cleaning gets done well if you're going to shorten the time. And then as we just alluded to, sometimes there are just too many people doing cleaning in the room. Another big issue, another challenge that people consistently see is staff that are not well trained. There are a lot of important things that are happening in the operating room. And in about 50% of hospitals, it's clinical staff that's doing the room turnover cleaning. And if you think about clinical staff, and I'm a nurse myself, I can tell you that's not, cleaning and disinfection was not necessarily something that we were trained on in our training for healthcare, for medical school or for nursing school or anesthesia school. And so staff are not necessarily well trained on how to clean or what's important to do or what are the high touch objects that they should focus on. And then the last thing, which can really impact efficiency, is that the tools aren't available at the point of use. The staff hasn't spent time figuring out what they need to turn over a room and getting it all in an organized place where they can do it quickly. And so these are some of the common challenges that we see when we're trying to optimize room turnover to clean better and faster with fewer people. And so some of the success stories that we've seen are this first example, which was in a community hospital in Huntsville, Alabama. They have 19 operating rooms, and at the time they were doing 13,000 surgeries per year. And their specific challenges were that their high-touch objects were not consistently cleaned. They didn't have any method to know when the room had been cleaned, because it's a, you know, if you look at a room, it always looks cleaned or could potentially look clean. So there wasn't any way of knowing that the room had been cleaned. There wasn't any standardized process for room turnover. And then they were using a bleach disinfectant on all their high-touch objects. It had a 10-minute contact time, which was hard to maintain, and it was damaging a lot of equipment. And so the recommendations that were brought in were working side by side with the hospital staff to facilitate a process improvement and create a standardized room turnover for them, to provide on-site training for all staff. And that's a really hands-on training. Oh, my slides just skipped back to the beginning. Not sure how that happened. Bear with me. Okay, back to where I was. And so we worked side by side, and we provided training for all staff, not just the staff that do the cleaning, but everyone in the operating room, because it's important that everybody understands what the process is and how important it is so that they can support the process. We introduced some new environmental hygiene products and tools to get all those products at the point of use and to make it a more streamlined and efficient process. The hospital implemented environmental monitoring using a fluorescent marker, and they started using a disinfectant cleaner that was a sporicide, but it did not damage equipment. And you can see from the charts at the bottom the improvement that was seen by implementing these optimizations. Their between case cleaning at the beginning was 28%. So they were cleaning 28% of high touch objects. And if you think back to the study I showed you earlier, the average is 25% that we had seen in the study that was done. So they were pretty close to what we usually see. And that was both for between case and terminal. And you can see that after this program was implemented and this standardized process was implemented, 2 months after implementation, they were still cleaning 95% of high-touch objects, and 6 months later, they were cleaning 97% of high-touch objects between cases. Terminal cleaning was a little harder to bring up to speed, but eventually, after 2 months, they were at 70% of high-touch objects cleaned, and after 6 months, they had 86% of high-touch objects cleaned. And in addition to having them clean more thoroughly, their room turnover time decreased. So their baseline room turnover time was 14 minutes. So they were taking 14 minutes to clean 28% of high-touch objects, and that's between cases. And after the implementation, their turnover time was 9 minutes. And so saved time and cleaned better and optimized how many people were in the room. Some of the other outcomes that they saw was that they saved $15,000 a year on their OR mattresses because they weren't having to replace them because of the damage from bleach. And then they also saved time, and that translated to dollars, or could be translated to dollars. And so, you know, you might say, well, we're not going to necessarily be able to add more cases. You could potentially add more cases if you significantly reduce turnover time. But the other thing you're doing is you're allowing more time in that turnover time for more patient-focused activity, like setting up for the next case, making sure your medications are correct, having time for that safety moment before the surgery starts. And so by optimizing cleaning, you're allowing time for other between case activities that are very important. And this is another example. This was in a larger quaternary care hospital in an urban center. They had 27 operating rooms and did 23,000 surgeries a year. And they were really seeing poor cleaning with their high-touch objects. They didn't have a consistent process for their OR turnover. They didn't have a method. They weren't doing any kind of monitoring to know how well they were cleaning. And they had high staff turnover. They had a dedicated staff that did environmental hygiene for between case cleaning. and they had a very high staff turnover rate in that group of people. So again, they implemented a standardized cleaning process. We provided training for all of the staff, including the clinical staff, so that they would understand the process. We optimized the tools. They started providing some monitoring and feedback on how well people were cleaning using a fluorescent marker. They started using surgical room turnover kits. So instead of reusable linen, they went to disposable linen, which speeds up the turnover time and also makes the table, OR table, a little bit easier to clean. And they used point of use cleaning carts and tools that were optimized for the space. And you can see they started at 20% of high touch objects being cleaned between case, and 2 months after implementation, they were at 86%. And their OR turnover time decreased from an average of 30 minutes to 9 minutes after implementation. That's an average. Obviously, cases take shorter or longer depending on the type of case, but they saw a significant reduction in their room turnover. And their estimate was that they were saving about $800 per room. They had tried to do some studies, and it's very hard to do, to identify the cost, the total cost of a minute of OR time. And so this is what they equated it to. But another important thing that came out of this was staff retention. So remember, I told you that the staff that does the cleaning in here was a dedicated environmental services staff that worked just in the operating room, turning over rooms. And they were feeling pretty beat up, and that's why they had high staff turnover. The clinical staff didn't have confidence in the work they were doing, and was constantly telling them that they weren't doing a good enough job. And after we implemented this program, and they really had a good solid training on how to turn the room over, and we trained the clinical staff on the process as well, it really gave the staff that was doing the cleaning a much better sense of importance, knowing that their role had made a difference, and the clinical staff was more supportive of them. And their staff retention increased significantly because of that. And they also anticipated that they had saved several hours. And so you can see that you can optimize cleaning faster, cleaning better, and in this case, improving some staff retention and some staff morale at the same time. And so we've talked about the impact on operational efficiency, and we're talked about the impact on thoroughness of cleaning, but this study shows the impact on patient outcomes, which is what we're really looking for at the end of the day after all. And so in this particular setting, they implemented the program that I just described in the previous two slides as part of a multimodal approach to reduce surgical site infections. And so some of their challenges were that they had too many surgical site infections in their opinion, especially linked to colon, spine, total hip, total knee, and cardiac procedures. So they were seeing 2.59 SSIs per 100 cases. So 2.59% of their cases were seeing surgical site infections. They felt they had suboptimal interprofessional and interdepartmental collaboration. They weren't working well together, and they didn't have a method for determining how well they were cleaning. And so their recommendations and optimization was to educate patients on hygiene and signs of surgical site infection. And they included focusing on CHG bathing the night before and the morning of surgery. So that patient bathing piece, I talked about the chain of infection at the beginning. They're addressing patient skin and ensuring that they're decreasing the bioburden on the patient's skin. They enhanced environmental cleaning using the same process that we just talked about, looking at surfaces and equipment. And they administered nasal iodine swabs within 1 hour prior to surgery to reduce Staph aureus colonization in the nose, which has been tied to surgical site infections. And then they implemented, they implemented surgical team regowning, regloving, redraping, and the use of a new sterile table and instruments to close the surgical procedure, because they had read some studies that showed that might have an impact on surgical site infections in those particular cases that they were trying to address. And you can see in the outcomes below that they cut their surgical site infections nearly in half over that 2-year period of time, from 2.59 to 1.36. And so I'll just point out that the environmental hygiene parts of that was that interdepartmental collaboration was very important, of working more closely with environmental services and partnering with them. And then in addition to that, the environmental services staff was educated, their performance was audited, and they were given feedback and education on their performance. And all of those things contributed to a reduction in surgical site infections. And so we've talked about how you can improve the process, you can improve the efficiency, you can improve the thoroughness of cleaning. And this study shows that you can also use environmental hygiene as a way to reduce surgical site infections. And so what is the process? I've kind of been reiterating it throughout this, but this is really the bones behind all of this. What is the process that you use to optimize environmental hygiene in the operating room? The first is recognition of environmental services impact on quality and on infection prevention measures. And some of that is done using program dashboards or information. I'll show you a picture of a dashboard in a moment. But it's really important to recognize that environmental service is part of the quality, the patient safety of your hospital. The second is to have a programmatic approach to in-person and on-demand training. So a really good combination of face-to-face, hands-on training, not just classroom training, but hands-on training. And then also some really good distance learning or on-demand learning opportunities, because you have to be able to reinforce it as new people come on board annually, as new products are brought in. And then the next thing is product standardization, as I alluded to earlier, using the right products for what you're using and as few products as you can possibly use to eliminate confusion, so people all understand what the contact time is, how you're supposed to apply it, important things that make sure that the product does what it's supposed to do. And then what I've hammered on throughout this, a repeatable, measurable, sustainable process for room turnover. And sustainable is very important. We've all done quality improvement initiatives that are effective, but they don't last. And so it's really important that you find a program that's sustainable. And so a combination of the things that we've talked about before with training, hands-on training, monitoring and feedback, standardized process that everyone understands, good communication is really key to sustaining. It's kind of like the Fitbit or the Weight Watchers program. It's something that you can go back to time and again. And then you have to have an objective way to evaluate how well people are cleaning. And so that's a very important component. And one of the training tools, I'll back up for a minute. These are just examples of a couple of the training tools that can be used. So the top two are flow charts that are very clear and consistent on the process that's supposed to be followed. So you train to a process and you have leave behind tools for people to make sure they understand what the process is, and if they can't remember it, they can go back and look. And then on the bottom, it shows a high touch object card. So it's telling you what to focus on when you're doing that between case cleaning, so that you don't have to rely on your memory to do it correctly. And then the last thing is actionable insights. The blue bar at the bottom was where I left off. And it's really important to have actionable insights to be able to share with the frontline staff and the stakeholders. And so this is an example of a dashboard from a program that gives feedback that can be shared with both the frontline staff and the stakeholders, the hospital leadership, that gives information on how well they're cleaning. So the picture on the left is their percentage of high touch objects are cleaned, that have been cleaned, so 82.6% in their example here. The middle is the average amount of time saved per operating room. So they're measuring the amount of time they're spending cleaning in the operating room, and they're keeping track of that and reporting it. And then their adherence to processes and best practices. And then down at the bottom in this particular dashboard, they're showing at a system level all the different hospitals and how each hospital is performing. And from there, you can dive down into individual hospital performance all the way down to individual healthcare worker performance on environmental hygiene. And so this kind of actionable insight is incredibly important, because it's just not good enough to go in and tell everybody, you're not cleaning well enough, or you're doing it too fast or too slow, or you're not following a standardized process. You have to be able to give specific insight to people, and you have to be able to tell me, for instance, Linda, you're doing a great job on this, but I noticed you're missing that, or I noticed it's taking you a little bit too long to turn the rooms over these days, especially in these cardiovascular rooms. What can we do to help you speed that up? And so actionable insight is incredibly important. And so this is essentially what the process is. And the truth is that the Centers for Disease Control agrees with this. So this process back here was first implemented about 6 years ago. And about a year ago, the Centers for Disease Control came out with the core components of environmental cleaning and disinfection in hospitals. And you can see as you look at this, that it really does mirror very closely the process that we just talked through. And so you can go to the CDC website and you can see very detailed instructions on what each of those steps should entail. And it's very important, and it's good to see that it's recognized as an incredibly important process to follow by the Centers for Disease Control. And so here are the key takeaways. Emerging pathogens are going to continue to arise. We have COVID right now, and now we're starting to think about other emerging pathogens like C. auris. There'll probably be more. We know this isn't the end, and they're always going to cause some threats to our patient and our staff safety and our operational efficiency. And as surgical volume returns from COVID, or as we're dealing with these other emerging infections, patient and staff safety and operational efficiency have to be balanced. You have to ensure that the patient is safe, but you also have to do that as efficiently as possible. And operating room turnover is an example of one of those fast dances that has to be orchestrated and done with precision so that you can optimize the outcome that you get from the time that you have. And a standardized process can ensure that you strike that balance between safety and efficiency, that you can clean better with fewer staff in less time. And it is possible. I hope I've been able to show you today that it really is possible. Change is hard. It's hard to change behavior, but with the right process, it can be done. If you think of it as something that's giving you consistent feedback and input on performance, we can change behavior, and that has been seen in areas outside of healthcare, and it's also been seen in healthcare. So I want you to leave thinking that change is possible, and it can be done. And so with that, I will thank you, and I will turn it over to see if there are any questions.
Thank you so much, Linda. We do have some questions that have come in, but as a reminder to the audience, please use the questions feature on the webinar dashboard if you would like to submit a question for Linda. Our first question is, the science that you presented all makes sense, but it doesn't change our realities in terms of staffing shortages. How does a programmatic approach help when we have staff shortages?
Yeah, so I think that's a good question, and I hope I touched on that when I talked about the fact that if you can standardize a process, you can make it as efficient as possible and hopefully be able to do that with fewer staff, with good communication and feedback. And so I think a standardized process, a well-defined process, good communication between people can work. So for instance, if you have a standardized process in the operating room, and if Joe Blow is in there cleaning and then I walk in and he's halfway through, I can tell what's been cleaned and what hasn't been cleaned based on where he is in the room. And so then I know what I can focus on to help him get done more quickly, rather than sending 4 people in and have everybody run around and wipe stuff down and clean some things twice and other things not at all. And so I feel like a standardized process can really do the best you can with the limited staffing that you're dealing with at the time. I hope that answers the question.
Thank you. Our next question is, if we collect monitoring data, how do we keep track of and make sense of all of this data?
Yeah, that's an ongoing challenge because, you know, for quality assurance, we're collecting data all the time. And so I think one of the best things you can do is try to find a program that can collect the data, analyze it, and report it back to you on a dashboard similar to the one that I showed you, because it is a lot of data. And another good example is hand hygiene. We're all thinking about how to do hand hygiene compliance and how to make sense of it. And again, it's finding a program or a system that can collect the data and analyze it and give you some feedback is critically important. I don't know why my slides keep popping back, but yeah. So hopefully that answers the question. I apologize.
That's great. Thank you. Our next question is, how do you know that if you roll out a programmatic approach that it's going to last?
Mm. Yeah, I think the key to that really, as I talked to about throughout this is, as I said, we've all implemented programs that worked but didn't last. And I think that it's that continuous monitoring and feedback and coaching and reinforcement of the program that really makes it last. And so if you can implement a system or a program that helps you do that so that you don't have to be the person focused on it all the time, but the program is doing it for you, then you can take your eye on the ball and focus on the next quality improvement initiative or the next efficiency initiative. And so it's really, it can be sustained, but it takes some outside help sometimes to make that happen.
All right, our next question is, what environmental hygiene monitoring methods are available and which ones are most effective?
So there are essentially 4 different environmental hygiene monitoring methods. One is direct observation. So that's me, basically the white glove test. You clean and I come in afterward and look and see if it looks clean. Or alternatively, I watch you clean and coach you and give you feedback. And that's an effective tool for training and for feedback, but it's not objective because you know that I'm watching you and so you're going to clean better. The second method is culture, environmental culture. So I showed you that study where they took cultures of the environment because they thought they were having surgical site infections related to the environment. But culture isn't a very practical way to evaluate how well someone's in cleaning because it's very labor and resource intensive and gives you more information than you really need. And it takes about 2 days to get the results back. So it's not particularly helpful for continuous monitoring and feedback, although it's very accurate. The third method is adenosine triphosphate, or ATP, fluorescent ATP, and that's a method of evaluating whether there's organic soil on the surfaces. So you swab a surface with a specialized swab. You insert it into a luminometer that gives you a readout that tells you a proxy for how much organic material is on the surface. And there are limitations with that as well, but it's an objective method to evaluate how well cleaning happens. And then the fourth method is fluorescent markers, which I've talked about in this presentation. And that's placing a fluorescent dot on a surface that's basically not visible to the naked eye. And you do that before cleaning takes place. And then after cleaning, you come back in with a black light and you see if that mark's been removed. And it's a really good measure of cleaning process, which is what we've talked about today. It's just telling you, did that mark get removed? Was that object cleaned or not? It's not telling you anything about organic load or what kind of bacteria is growing on the surface. It's strictly telling you an objective way of telling you whether the surface got cleaned. So those are the 4 basic methods that you can evaluate environmental hygiene today.
Thank you so much, Linda, for your time today and for a great presentation. I would like to encourage everyone to visit today's sponsor to learn more about the products and services they provide to our industry. Please visit ecolab.com. A quick reminder that you can obtain your continuing education certificate by completing today's post-webinar survey. The survey will be emailed to you 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 continuing education hour, and you'll be able to download your certificate immediately once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll be back soon with another webinar. Please visit ortodaywebinars.live for more details and complimentary registration. Thank you all and have a wonderful afternoon.
Thank you.